Okay, hi everyone. Good, how are you? So my name is Natasha Lee. I'm a third-year resident in internal medicine and pediatrics from Tulane University in the US. I'm also here with one of our palliative care physicians at the Malaga Hospital, Dr. Natasha. So we're here to really address the palliative care aspects in this particular patient. But before I, get into the details, I wanted to give a very brief overview of what is pediatric palliative care exactly. So it's really specialized care that's focusing on the treatment of children with very serious illnesses, life-threatening diseases, and we're focused on improving the quality of life for both the patient and their family. Especially in pediatrics, you have to incorporate the family into the care since they're minors and they're going to be the ones who kind of make a lot of the medical decisions for the child. So because of this, it's all going to be very family-centered, and we're really trying to provide care that's in line with the patient and the family's values, traditions, and culture. It's really based on need, not prognosis. And I say this meaning that in palliative care, when you offer treatment, you're treating the patient regardless of whether it's going to change the disease outcome. You're really treating their symptoms, their quality of life, and so because of this, it's nice to start earlier rather than later. We also work with other medical providers. Palliative care is usually a consulting team, so you're touching base with the primary wards team, other consultants, and just making sure that all the information is, everyone's on the same page and that we're all providing the same message to the family and it's not mixed messages. And also just providing support to the medical teams as well, because sometimes dealing with a lot of these chronic illnesses can also be very trying on the medical providers too. And it's really appropriate at any stage of illness. So, a patient can be receiving their chemotherapy, but we can also be providing palliative care in terms of, pain and symptom management, as well as just providing good information for them. So in pediatrics, it tends to be a little more unique than what we see in adults. So for children, the prognosis sometimes isn't as clear as it is for adults. We may not be talking about just a shortened life expectancy. We may be talking about a change in the functionality of the child. So they may not be as mobile or kind of appearing as normal as other children. And so that's kind of the focus of our attention. The care tends to be dually focused, so we're treating children, so they are growing and developing, so you have to address those concerns. But then you're also treating a patient with chronic illnesses, so there's always a possibility of death that you have to prepare the family and the patient for as well. Pediatric palliative care can have greater emotional burdens to the family and the medical teams, because typically we think of children as very healthy and living for a long lifetime, or if they get sick, they recover very quickly. And so when you have more chronic conditions, it can be a little bit more emotionally trying for both the providers and the families. And then the patients themselves can pose challenges in terms of, sometimes these conditions they live for, like this child has been here for 12 years, and so how providers interact with the patient is going to change over time as they grow and they develop and they learn and become more mature, like how you talk to them, how you present information to them, and their treatment options changes over time as well. So all of this is a very, very brief overview, but we wanted to get into more of a discussion about the case. So, I can get some input from the audience as to when you all think we should consult palliative care in this case. Yeah. So ideally, at the diagnosis of tetralogy of Fallot, when the patient received that diagnosis, would be a good time for palliative care to be involved. And part of it is because even if he may not have had a lot of symptoms, 2 years ago, at least it provides a chance for the palliative care team members to establish a relationship with the family. You can make sure they're getting good information, and when complications arise later on in the disease course, they already know the palliative care team. So it's already a group of people that they trust, they can communicate with, and so when you are delivering bad news or unexpected news, at least it's coming from someone who they already have a relationship with. And so even if it's just an introduction, it's always good to involve palliative care early. We actually, the palliative care team had seen this patient in a prior hospitalization before. So overall, if you have palliative care patients that are readmitted, it's always good to just touch base and be like, oh hey, this patient is here again. And even if there's not a lot of active symptoms or something, just so you can stop by, say hi. If anything needs to be addressed, or they can spend a little bit more time explaining one of the tests or something like that, it's always very helpful to have palliative care involved early. So you all kind of talked about this before, so this is really just to show you just how complicated this patient really is. The problem list is kind of after we did our palliative care assessment for this patient, it's very extensive. And as you see in palliative care, you also focus on the psychosocial aspects of the patient. So, he's already been in the hospital for 3 months. He really wants to go home. He's writing it in his notebook every day that he wants to go home. The mom is also wanting to go home, and she's also expecting, and so that also complicates things. And then there's been a little bit more limited family support from the child's father in terms of, he's not really here, but they also have other children. And so it's a very, very complex case, not just medically, but when you also look at the big picture of what type of support does the child and the mother have in terms of moving forward with treatment, because unfortunately, you have to take all of that into consideration as to how are we going to manage this patient. And so something that's a little bit more straightforward is, his pain and symptom management. So his pain was pretty severe when he came in, and so this is the 2-step analgesic ladder for children. So usually you start with non-opioid pain medications like paracetamol, ibuprofen, if they're old enough, and then if that's not working, then you can transition to stronger pain medications like opiates, like morphine. So he's actually been getting morphine, but there's a lot of, I think, hesitation in the pediatric population to prescribe morphine because it's such a potent medication. And so when you are prescribing morphine, if a child has severe pain, you want to control their pain. And so it's a lot of it just surrounds education. Morphine can be a safe medication if you're dosing it correctly and you're administering it correctly. And so the mother actually was, when we first saw her, she wasn't really giving the morphine because she was so scared. And when you discuss with her, it's the small dose, it's given at, these intervals, these are actually safe doses for him, it at least allowed her to feel a little bit more comfortable in administering the morphine, which is important because, we want to keep him comfortable as he's been here, and he has a lot of reasons to have a lot of pain, and so we want to treat his pain and at least improve some of his symptoms while he's here, especially if it's, he has such a complicated medical history. We can't always, address all of the underlying factors, and so if you're going to treat symptomatically, we want to make sure the treatments are effective. And then kind of the bigger question of goals of care. So this is a really, really complicated topic, and it's different for every patient. So in the sake of time, I'll say, how we approach goals of care for this particular patient was, we wanted to manage his symptoms, especially his pain, which we discussed. And we wanted to make sure that there was good communication between, the mom's understanding of what's going on, and he's 12, so even like the patient's understanding of what's going on. Good communication can at least relieve some emotional or psychological distress. If you're being kept in the dark and you don't know what's happening, at least you have some answers. And then the more complicated topic of how do we achieve quality of life for the patient and the family? And in order to answer that question, we really have to ask, what is quality of life? It's a hard one. Anyone have any ideas? Yeah, so that's a lot of different aspects though. So for this patient, how do you break that down?
For the patient, I think everything is how we may keep the cover
Yeah, it's not easy. And so I want you guys to think about this a little bit, because quality of life is actually very subjective. Like, my idea of quality of life can be very different from your idea of quality of life. And it can be different from the mom's idea of quality of life for her child too. And so when we talk about something, especially a patient like this who's very medically complicated, who has a chronic condition that we're not really able to treat very well, you have to ask really the patient and themselves as to what do you want out of your care. And it's really important to have this multifocal group discussing the quality of life, because the patient's idea of quality of life right now is like, he wants to go home, he doesn't want to stay in the hospital, and the mom also wants to go home, but she's very worried about how can she take care of this patient at home. He's so complicated, he has so many medical problems, like it's not exactly feasible to do everything that, by yourself at home. So you really have to, it's a difficult question to answer, because there's so many factors, and that's why it's really important to have good communication between the medical teams, the patient and the mother, and making sure that everyone really understands, like has a real understanding of the consequences of if they do go home, do they know what that really means going home. It's not just to see his younger siblings and to sleep in his own bed. It's really like, is she going to have a way to manage the bed sores? Is she going to have a way to treat the sepsis? Like, these are all things that you have to think about while knowing that his time is limited. And so you do want to, address his wishes the best you can as trying to find a way of getting him home at some point. And so these are really difficult questions and things to think about, but that's why it's important to make sure that, they really have, she can also respond and tell you what her expectations are as a mother. And the patient, he's 12, he has input, into what he wants as well. And so it's challenging, but it needs to be a very open discussion so everyone can make an informed decision about the next steps. Because there's no right answer, ultimately, which is hard. But yeah, it's brief, but